Great, thank you, Shireen. Welcome everyone to our LIDC Research Seminar on Mental Health for Development Professionals, an Introduction. This is the 10th seminar in the series, and it spotlights exciting research and initiatives taking place around our colleges and global development. And for those of you who haven't been to one of our previous events, London International Development Centre is a consortium of 7 University of London institutions, and we support interdisciplinary research and training across nearly 5,000 members who work across the full spectrum of global development. And membership is free for students, staff, and alumni of our member institutions, so please, you can find further information on our website. Now, today's speaker is Grace Ryan, and we are absolutely delighted to welcome her. Grace is a research fellow at the London School of Hygiene and Tropical Medicine's Center for Global Mental Health. She joined the center in 2012 after working for the INGO Partners in Health in Haiti, in Rwanda. And her particular research interest is in monitoring evaluation of mental health programs in sub-Saharan Africa. She's the lead researcher of the K4D DFID learning journey on mental health. And this is a project which helps equip development professionals with the skills to respond to the Sustainable Development Agenda on mental health. And I'm sure she's going to talk more about this project today. She's also one of the founding members of the Mental Health Innovation Network. And this is an online community of over 7,000 mental health innovators from around the world, and it's based at LSHTM in partnership with WHO. So today, Grace is going to outline the kind of key arguments for and successful examples of the integration of mental health across a range of spaces in global development, such from social protection and healthcare to humanitarian response. And she's also going to discuss mental health monitoring and evaluation and other kind of entry points for what she terms as doing more and doing better. After Grace has finished presenting, we'll unmute our microscopes and we'll unmute our microphones for questions from the audience, and I'm sure you would join me in giving a very hearty welcome to Grace.
Great. Thank you so much, Claire. If you don't mind just bearing with me for a second while I share screens. It's a bit tricky on this, so. All right. Is that working for you? Great.
Perfect.
Okay. All right, thank you so much again. I did just want to take a second to thank you guys at the London International Development Centre for organizing this seminar. I was a student at London School of Hygiene and Tropical Medicine before I started working here, and the LIDC seminars were the places where I met some of the most amazing kind of formative people in my academic development. So it's just really exciting to be doing this today. I also wanted to thank all of you for taking the time to join in, particularly after several weeks of lockdown that I know have been very tough on many of us. When the outbreak started, I remembered a bit of advice a friend gave me a few years back. She said that when something terrible happens, sit back and imagine telling the story to your grandkids someday in the future about how this terrible event actually ended up doing some good in the world. Ask yourself, what is that good, and what part can you play in making it actually happen? Now, as a researcher in global mental health, I'm really worried about the impact of COVID-19, and I find all these headlines we've been seeing really troubling. But when I take my friend's advice and imagine telling the story in the future, I actually feel quite hopeful as well, because I can also see this as a real turning point. Current events have hit home for many of us the importance of mental health to our personal lives as well as our work, and we can see this all too plainly in the headlines. Further, I think recent events are starting to lay bare some of the limitations of a kind of narrow view of mental health as primarily a medical or even a psychological issue, or for those of us working in development as something for the global health people to deal with, not really my problem. Dr. Rochelle Burgess, our colleague from UCL, wrote in Nature earlier this week that a woman who's lost her job and cannot feed her family will find little relief from a meditation app, which I think is very true. We need a more holistic intersectoral approach in order to really make a difference in people's lives. So the headline for my talk today, and it's good news, is that there's a role for all of us to play in improving mental health around the world, no matter what sector of development we're working in. And perhaps COVID-19 could even be the catalyst that finally makes that happen. That's the story I want to tell my grandkids. And if we're going to make it a reality, I think there's 3 things we really need to do as a development community. First, we need to evaluate the impact of development interventions from diverse sectors on mental health. Second, we need to ensure that people with M&S conditions and psychosocial disabilities are actually included in the good work that we do in other areas of development so that those in the most vulnerable situations can benefit. And finally, we might also consider integrating mental health specific interventions into our work if it's appropriate, but I understand that's not going to be the case for everyone. For example, if you're working on violence against women and girls, chances are many of your clients could benefit from an evidence-based counseling intervention or something like that. In contrast, if your focus is on clean water and sanitation, you might find it more difficult to make a case for that. But we're going to talk about all of this in over the course of this brief talk, and I'm really looking forward to also hearing your questions and your ideas about how we can do more and do better for mental health and development. I should add that these 3 points, as much as I'd love to take credit for them, are not new. They build on recommendations to non-governmental organizations issued by the All-Party Parliamentary Groups on Global Health and Mental Health back in 2014. And yet we still see rather few UK-based NGOs acting on these recommendations 6 years later. Now, after a couple of years working with development professionals at the Department for International Development and the Bond Group for UK NGOs, I've come to believe that the slow rate of change is not due to a lack of interest or enthusiasm for mental health. To me, it's really down to 2 things. First is confidence, and the second is funding. And unfortunately, I can't really help with the funding bit myself, but I think we can start building our confidence to do more and do better by getting back to some of the basics. So first, we need to be able to speak confidently about mental health without worrying about accidentally saying the wrong thing and sounding silly. So the terminology in this area can be contentious, and our topic guide actually starts off with some of the do's and don'ts that you might like to take a look at after this presentation. But for now, I just want to run quickly through the terminology that we're going to be using in the talk today. So the first is mental health, and this is a definition from the WHO. It's a state of well-being in which every individual realizes his or her own potential, can cope with the stresses of normal life, can work productively and fruitfully, and makes a contribution to her or his community. So when we're talking about mental health, we're really talking about a spectrum, and the WHO definition of mental health is kind of at the good, positive mental health end of the spectrum. On the opposite side of the spectrum, you might find yourself with a mental, neurological, or substance use condition. And you might be wondering why I sort of breeze through this like they're one thing. I call them M&S conditions or mental, neurological, substance use conditions, as though they're kind of one category. When in a lot of high-income countries, including the UK, we think of these as 3 very, very distinct sets of conditions: mental health conditions, neurological conditions, substance use conditions. But in many parts of the world, they're viewed as kind of similar issues and are treated through similar means, oftentimes through the mental health system. And this is one reason why global mental health, my field, deals with M&S conditions, not just mental health conditions alone. And often when you hear us talk about mental health, we're talking about all 3 of those sets of conditions. And finally, I think this is a really important definition for us to kind of grapple with, and this is psychosocial disabilities. And I think a lot of us have trouble understanding what that means. Essentially, someone with an M&S condition doesn't necessarily have a psychosocial disability. A psychosocial disability is the product of impairments that might arise from an M&S condition in interaction with various barriers in society that restrict full and equal participation. So it's a view that's less about impairment and more about the way society responds to those impairments and includes people who might be experiencing them and accommodates them. And I actually think that's a really profoundly empowering concept, because it gives those of us who are working in areas of social change a lot of agency to help reduce psychosocial disability. All right, so in addition to some of the basic terminology, in order to feel really confident about mental health, we also want to have at our disposal some of those handy little facts that can help us make the case within our organizations that mental health really matters. And our topic guide is just chock full of these, so again, do check it out. But here are a few that we can start with just to hit the point home. So for folks working in global health, you might have come across concepts of the global burden of disease, which is basically a metric for measuring public health that takes into account both mortality and disability data. So M&S conditions are responsible for more than 10% of the global burden of disease, and by some estimates, 13%. So that puts them on par with cardiovascular disorders or cardiovascular diseases, which are currently the #1 cause of the global burden of disease worldwide. M&S conditions are the #1 cause of years lived with disability. Again, that's one component of the global burden of disease metric. And partially because of the disability caused by M&S conditions, they also result in a loss of economic productivity, which for low and middle income countries amounts to 7.3 trillion just over a 20-year period, taking us to 2030. The global loss is 16 trillion, so nearly half of that is coming from low and middle income countries' economies. There is a 4-to-1 return on investment in mental health, especially for common mental health conditions, as estimated by the World Health Organization. So there's a really strong economic case for us to be investing more in mental health, and yet less than 1% of development assistance for health in low and middle income countries is actually dedicated to mental health. So there's a real mismatch between the resources and attention that go to mental health in international development and basically any metric by which you measure the importance of mental health, whether you're looking at disability, whether you're looking at global burden of disease, whether you're looking at economic losses, or whether you're looking at human rights arguments, which we're not going to talk a lot about today, but there are indeed very many. All right, so third, in order to feel really confident about our role in mental health and development, we want to be able to articulate how this issue aligns with national and international development agendas. So mental health is covered in Goal 3 for health of the UN Sustainable Development Goals, but basically wherever disability is covered in the UN Sustainable Development Goals, mental health and psychosocial disabilities are also covered, so in 5 of the 17 other goals. The UN Convention on the Rights of Persons with Disabilities includes people with psychosocial disabilities. It's been signed by 160 countries. It entitles people with psychosocial disabilities to the full spectrum of human rights. And it's a really interesting document for you to consider because it goes beyond just a health perspective on mental health, like I mentioned earlier, to also consider our rights to a family life, our rights to live in a community. And it can be a really expansive way of approaching mental health beyond the health sector. Of course, the WHO Mental Health Action Plan has also been ratified by all WHO member states, and it outlines 4 key objectives for us to achieve by 2020. Unfortunately, we made some progress, but not quite enough. So it's been extended to 2030, and hopefully all of you are going to help us get there in the next 10 years. And for those of us working in development in the UK, it's also worth mentioning that mental health and psychosocial disabilities were highlighted in both the 2015 and 2017 reviews of DFID's disability framework as an area that really needs more attention and more focus from the organization. And there will be an event coming up in a few weeks later this month where DFID's going to outline some of the ways in which they're responding to the recommendations of those reviews. So watch this space. All right, so hopefully by now you're feeling a bit more confident about mental health. We know some of the basic lingo. We've got our fun facts in hand, and we understand that no matter what area of development we're working in, we have a mandate to do more and do better for mental health. So now we're probably starting to ask ourselves, what do we do and how do we do it? And it's time to revisit those 3 points I introduced earlier. Now, I realize this is kind of a scary looking diagram. It's from the Lancet Commission on Global Mental Health, but I think it helps us to conceptualize these 3 points a little bit better, so please bear with me. First, just take a look at the axes. Looking at the y-axis, you might be reminded of what I described earlier with mental health as a continuum ranging from mentally healthy to at-risk to poor mental health or even to psychosocial disability. Now look at the x-axis. So this is telling us that mental health is something that stretches all the way across the life course with different risk factors and different possible leverage points for intervention from preconception through to adolescence and youth and on to adulthood. At the far right, those bubbles also remind us of something else that's important. Often when we talk about mental health interventions or about integrating mental health into our work, we think about offering mental health treatment. So that was my, I think, point 3 on the previous slide. And that's maybe one reason why many development professionals feel that mental health is none of their business, because they don't really know how to go about doing treatment. But I would argue that whether you're working on clean water or climate change or girls' education or pretty much any area of development, you could be contributing to prevention and promotion by addressing risk factors across the life course, or even to recovery by ensuring that people with MNS conditions and psychosocial disabilities are included in and benefiting from your work. So that's our points, I think 1 and 2. Okay, so let's drill down for a second on prevention. Prevention is all about minimizing exposure to risk factors, and also promotion on the other side is about shoring up those protective factors. This diagram focuses on risk factors. It's developed by researchers at the Center for Global Mental Health who've mapped the various risk factors for mental health conditions directly onto the Sustainable Development Goals. So they're showing how our efforts in development more broadly can actually help to protect mental health. I think let's zero in on number 1 here under economic, under the goal for no poverty. So the relationship between poverty and mental health has often been described as a vicious and mutually reinforcing cycle, with poor people more likely to become and to stay unwell, drifting further into poverty, and vice versa. So right now we have pretty good evidence that providing effective treatment interventions to people with MNS conditions improves economic outcomes. Unfortunately, mental health outcomes of interventions for poverty reduction are rarely measured. So even though work on poverty reduction is probably affecting mental health, we don't have the evidence that we need yet to identify our sort of best buys for mental health prevention. Evaluators working in this area of development could make a tremendous contribution simply by measuring the mental health outcomes of the work that they are already doing. And it's not impossible to do. There are already some promising studies of cash transfer schemes, for example, that have improved mental health. So this is an evaluation by a colleague of ours from the Center for Global Mental Health suggesting that Brazil's unconditional cash transfers may have played a role in suicide prevention. The topic guide is also full of a number of other examples where social protection interventions such as cash transfer schemes, pensions, funds to assist schooling have actually had some form of mental health benefit, which I'm not going to go through now, but I would encourage you to take a look at the topic guide. We still do, though, need more research in this area. I'm highlighting that there are a number of examples while telling you, please do more research. We need more research, which I realize is a bit of a contradiction. Okay, I've used poverty reduction to explain why evaluation is needed to build a better evidence base for prevention. For this point on integration, though, let's talk a little bit about physical health. So mental and physical health are hard to even separate because they are so closely linked. But here are some examples where we have good evidence of the importance of mental health to physical health outcomes. So the first point is on high comorbidity with communicable, non-communicable, and neglected tropical diseases. What this essentially means is that mental and physical health conditions oftentimes go together. So for many conditions, having an MNS condition is actually a risk factor for developing a physical health condition, and vice versa. Having a physical health condition can be a risk factor for developing an MNS condition or for worsening the symptoms of an MNS condition. Now, why does this matter for those of you working in physical health? Well, actually, because of this closely intertwined relationship between physical and mental health, having poor mental health can actually negatively impact the physical health outcomes that you're hoping to improve through your work. One of the mechanisms by which this might happen is through affecting adherence to immunization and vaccination for infectious diseases. But another one is adherence to treatment for physical health conditions. And there are a ton of examples of this from cardiovascular disease, diabetes, HIV. Again, a lot more about this is available in the topic guide. The example I want to focus on today, though, because it is Maternal Mental Health Day, believe it or not, is the impact that maternal mental health can have intergenerationally. So maternal mental health, we know, impacts infant and child health and development in some really important ways. A systematic review from studies in low and middle income countries has concluded that providing treatment for women with common perinatal mental health conditions like perinatal depression actually improves maternal mental health, but can also improve a slew of other outcomes, even in low and middle income countries. Even better, these treatments did not require a psychiatrist, a psychologist, or another mental health specialist. In Pakistan, for example, the Thinking Healthy program was originally delivered by lady health workers, who are community health workers working in maternal and child health. And the Thinking Healthy program is now even being adapted so that it can be delivered by peers who are supervised by these lady health workers. So you don't necessarily need to have a psychiatrist on staff in order to be able to do some really good work in mental health that helps you to achieve your other development outcomes. And in this particular example, physical health outcomes, development outcomes. Okay, but even if integrating a mental health intervention into your existing work is not really feasible or just isn't your cup of tea, it's still important to remember that people with M&S conditions and psychosocial disabilities are often among the most marginalized groups in society and may need to be more proactively targeted in order to benefit from the work that you are currently doing. The WHO produced a report a little while ago on mental health and development that showed some shocking examples from around the world of where people with M&S conditions and psychosocial disabilities have been excluded from development interventions. And they actually concluded that this particular group is among the most likely to be left behind from development interventions around the world. These are just a couple of examples that are highlighted in the report. The first from Kosovo, where during the conflict, workers from the psychiatric institution fled, leaving the residents locked inside. Many people died as a result. In terms of social protection in Uganda, there was a microcredit scheme that explicitly set out restrictions in terms of accessing loan, or in terms of granting loans to people with M&S conditions and psychosocial disabilities, because they thought it was too much of a financial risk. So despite this cyclical relationship between poverty and mental health that I mentioned earlier, which would suggest that actually people with M&S conditions and psychosocial disabilities are exactly the kind of people that you want to include in your social protection schemes, they were being left out. And then there's another example here from Burundi, where children who have M&S conditions are sort of last in line to get any sort of access to education when there's a financial barrier involved. So it can be challenging to actively target and monitor the inclusion of people with M&S conditions and psychosocial disabilities. If you've already been working, for example, with the Washington Group questions on disabilities to monitor inclusion of disabilities generally in your work, you may have noticed that the tools for monitoring inclusion of psychosocial disabilities are still kind of evolving. They're not perfect just yet. But I want to point out that it really is possible to improve inclusion of people with M&S conditions and psychosocial disabilities in your work, because I've seen it with my own eyes. And as I speak, we're working on a paper about a really wonderful community-based rehabilitation program that was originally created for people with physical disabilities in Bangladesh. They were already doing really good work, but when they would do community surveys to identify people in the community who could benefit from their services, they kept finding people with intellectual and psychosocial disabilities who were in extremely vulnerable situations, and they just didn't have anything to offer them. So instead of setting up a parallel mental health project, as I've seen some other CBR programs do, they really just started including people with intellectual and psychosocial disabilities into their regular activities and kind of identified their needs and proactively sought out solutions for them in that process. So they didn't necessarily need to have a whole mental health program or a whole roadmap for how they were going to address mental health. They took the first step by just saying that people with psychosocial disabilities deserve to be a part of everything that we do, on equal footing with anyone else, including other people with physical disabilities, and they went from there. There's been some really cool stuff happening with that program that I'll be very excited to share once this paper's done. All right, so just to recap, I hope this diagram doesn't look quite so scary anymore. You've seen an example of how evaluating poverty reduction interventions can help us to build an evidence base for prevention to break that vicious cycle between poverty and M&S conditions. You've seen an example from maternal mental health of how integrating treatment and care where appropriate can actually help to improve other outcomes beyond mental health. And you've seen an example from disability rights where it's possible to support recovery by including people with psychosocial disabilities in existing programs, rather than necessarily having to set up your own parallel mental health projects. Our topic guide shares these and a lot more ideas about evidence-based entry points and opportunities to do more and to do better across many different sectors of development, including some that we didn't have time to cover today in much depth, such as humanitarian response and youth empowerment, which might be particularly relevant to many of you on the call. We developed this topic guide specifically for development professionals just starting to dip their toes into the subject, who might otherwise be feeling a bit overwhelmed by all the information and resources out there and might just not know where to start. So this is free, it's available online. Please do take a look and share with your colleagues. In the meantime, I hope this webinar has given you maybe a bit of a taster and that you can feel more confident to carry forward with your own self-study and learning by doing in this area. Also, as part of our learning journey with K4D and the Department for International Development, we've put together a webpage on the Mental Health Innovation Network with loads of different resources on mental health, specifically for development professionals. And the last chapter of the topic guide also includes a list of resources where you can learn more. So I definitely encourage you to check that out. And finally, for those who are looking for more topical resources specific to COVID-19, MHN is working with the WHO to collate useful resources and stories from the field. And you can also keep an eye on our Twitter at MH Innovation for updates, including information on some other webinars that MHN has been organizing with different partners, such as United for Global Mental Health. I'll close here with just a huge word of thanks to all of you for being a part of this silver linings story of change that I hope we can all tell our grandchildren someday. We all have a role to play in mental health, and even by just signing up for this webinar, you're taking an important first step. So thank you so much, and I really look forward to hearing some of your questions.
Thank you for that, Grace. That was really fascinating. And I think you've very much hit the bill on telling us what is good and how you can make that happen in the mental health space. So we're grateful for that. So are there any questions from the audience? Or should I use my chair's prerogative, Grace?
Feel free.
I wanted to ask you, when you were talking, I mean, are there sort of countries and nations where there's like that are just more geared to mental health and the rights-based framework? And are there sort of national level success stories that you could talk about?
Gosh, well, the WHO says that we're all developing countries when it comes to mental health. So I think it's hard to pick out a particular country that's doing a great job. There are areas of countries that I think I've been really impressed by. So our friends at the Quality Rights Gujarat Project have been doing a really exciting project of rights-based mental health care reform statewide throughout a very large state in India over the past few years. They've done it by involving peer volunteers, so people with lived experience of M&S conditions who are actually employed within the health sector to provide support to other people who are experiencing M&S conditions. I think that's a really exciting model for actually harnessing and leveraging people with lived experience as a human resource for mental health, because that's one of the biggest challenges and barriers to delivering effective mental health care in low and middle income countries is the extremely limited number of specialist mental health care resources that are available. So if you can harness that lived experience and expertise, it's a really kind of cool way of moving forward. And you're also working with people who have an intimate understanding of the challenges that they face in daily life that are not necessarily just linked to symptoms, but actually linked to being treated equitably in society more broadly. I think we do have Quality Rights Gujarat and some other similar projects highlighted in the topic guide. I keep plugging it, but do read it. Yeah.
Hi, Grace. This is Prerna from India. Could you just repeat which state that is and which organization is doing this work?
Great. So that's Quality Rights Gujarat. So, and it's through the CMHLP, which is, oh gosh, now I'm Center for Mental Health Law, Pune, I think. And Jasmine Kala and some other folks from that project might actually even be on this call. But they have a page on the Mental Health Innovation Network. I think they're featured in one of the call out boxes in the topic guide. And they have a really wonderful video that's available on YouTube if you look it up, where they kind of go through their work and how it also links to a broader project by the WHO to implement similar quality rights-based interventions in other low and middle income countries around the world.
Great, thank you.
Great. Do we have any other questions from the audience? I know Goon was organizing questions. I had another question. You spoke about the kind of protective factors versus the risk factors. Mm-hmm. And I think people in some respects, of course, might feel that some of these risk factors are out with their control in terms of working in development. But the protective factors, we could potentially support them, but it's quite a big ask. Like, do people come to you and say, you know, we're really interested, but how do we go about doing it? Our project cycles are very set often. Yeah. So what advice do you give people to kind of stretch that project cycle into accommodating some of these wider mental health issues?
Yeah, it's a tremendous challenge for those of us working in global mental health, because we are constantly saying we need to do more about prevention and promotion. How do we help people stay well rather than just kind of running to the scene when people are really struggling? That's what we would all love to be doing, but there's a real challenge in the development sector generally with these small project cycles and any kind of prevention and promotion intervention, whether you're talking about, you know, mental health or preventing other diseases. You don't actually have a long enough time span to follow up people and see if your intervention worked. And so for us, that's why it's such a priority to get mental health outcomes actually evaluated within existing programs, because wouldn't it be incredible if you had a cohort that's followed over a longer period of time in another area of development, where you could actually examine changes in mental health and see what worked and what didn't work. But I think that there's a real need for intersectoral collaboration to make that happen as well. Mm. A big challenge, again, for global mental health is it's largely led by folks, psychiatrists and psychologists at, you know, fancy academic institutions. It's been that way for quite some time. And when you have a hammer, everything looks like a nail, right? So if you're trained in mental health care and treatment and rehabilitation, that oftentimes seems like the solution, and it's the feasible thing that you can do in a shorter amount of time. But it's meant that our evidence base is so skewed towards treatment that actually we know quite little about prevention and promotion. And yet when we do see some studies done of this, for example, the cash transfer programs that have been done in Brazil, Tanzania, Malawi, and a lot of other places, and we see these really promising results for mental health, we all get quite excited, because ultimately, you know, I think that's where a lot of people working in this field agree the attention needs to go to, but we can't really do it alone.
Thank you for that. We had a great question from Anna Atunes Martins from LIDC. Anna, do you want to ask Joyce, raise your question?
I might say on her behalf, because I can just read it here on the chat. So I think it was, she said, thank you for a very inspirational talk. I wonder whether Grace could elaborate on the role of educational interventions in providing psychosocial support and ultimately improving children's health.
Great, absolutely. So I don't think I touched on this. I don't think I actually addressed your full question previously, Claire, which was on promotion and how we shape and support those protective factors. And equitable access to education is one of the key protective factors, one of the things that we really should be shoring up and supporting in order to improve mental health long term. That is, we do have evidence of that, and it is crucial. I think there's been some work looking at how best to integrate mental health into educational interventions, for example, sort of school-based interventions that have mental health literacy and awareness components that maybe create pathways for referrals for children who are really struggling into consultation and appropriate treatment. One of the big barriers and challenges with that is that, as few human resources as we have for mental health generally, child and adolescent mental health is even farther behind. I mean, it's really a huge challenge in low and middle income countries. And I think that can also create a sense of, I don't want to say anxiety, but maybe a sense of reticence to really enter the mental health space and to start working in that space when you don't necessarily feel that the country's mental health services have a robust enough child and adolescent mental health services that you know that you can engage with, and know when you find a child who's really struggling, you have some place for them to receive more specialist support. So that is an issue, but generally we do know that improving access to education and helping to support children and young people who are kind of struggling to stay in education has a protective mental health effect and is really important.
Okay, great. Thank you. We had another question from Oscar Sui, and he said, my question had to do with the role of religious and faith-based organizations in providing mental health support and how they might differ from the service provided from more secular development organizations.
This is a really interesting topic that, again, is quite under-researched. So I recently did a case study of a Nigerian mental health program, which was a public-private partnership between the Methodist Church, the International Development Organization, CBM, and the Ministry of Health. And what was quite exciting about this program was that they were able to build on mental health services that the Methodist Church had actually already been providing for quite some time, because they'd recognized that many of their members were either having quite significant mental health conditions or they had family members who were, and they developed a kind of community-based rehabilitation service to help meet their needs. And that was an expertise that actually wasn't available in the Ministry of Health at the time. So the NGO partner CBM almost kind of facilitated a partnership between those two, so that the Ministry of Health could learn from what the Methodist Church was doing, the Methodist Church could learn from what the Ministry of Health was doing. And they ultimately, working together, were able to scale up mental health care to all of 23 local government areas in a state of Nigeria that's the size of, I think, Botswana. It's huge. So I think that this is kind of an unexplored area, and I think we can have some reticence about working with faith-based organizations in development, but it's something that I think people are cottoning on to, that you probably should be partnering with the existing services, the existing support that's available within communities. And depending on where you're working, that might be religious organizations and faith-based organizations.
Okay, great, thank you. And we have two questions from Nigel Taylor. Could Grace apply what she was saying to the situation in LMICs with COVID-19 and associated restrictions, perhaps using the vicious cycle slide from Crick Lund? And how will this effect of restrictions apply to mental health, and how might these be mitigated?
Yeah, so I think one of the things that we're really worried about with COVID-19 is that it's exacerbating existing inequalities, and that services that were already not necessarily working so hot for people in vulnerable situations have been, kind of completely stopped or destroyed. And this is something that actually is not necessarily unique to COVID-19. It's a recurrent challenge in the aftermath of natural disasters and other crises in low and middle income countries, that oftentimes we think the main challenge for mental health is going to be the spike in depression, the spike in anxiety, the spike in post-traumatic stress that we need to address. But one of the biggest challenges we have is that people who had pre-existing M&S conditions or psychosocial disabilities aren't necessarily able to access the services or the other forms of support that they were previously using in order to stay healthy. So this is kind of a tension in the discussion on COVID-19 and mental health right now is how much should our focus be on the new incident cases that are resulting from exposure to kind of stressors that many of us have never been exposed to before in our lives. And to what extent do we really need to be focusing on kind of reaching out to people who had pre-existing conditions and making sure that they're okay within an extremely stretched service where all over the world, even where I'm from in the States, there's articles every day about how mental health services are just failing to cope even with the existing demand prior to COVID. So it is a really big challenge.
Oh, that's great. And we had a question from Purna Makar. Do you want to unmute your microphone?
Yeah, I had two questions, Grace. The first one is all areas in mental health we understand are very important. So it's probably a difficult question, but I'll ask it anyway. If a choice had to be made, which area of mental health should be prioritized? Adolescent, child health, maternal health? What should we tackle if we're in that decision-making capacity? And the other question is, what's the success of digital tools in amplifying or delivering mental health care?
Great. Well, number one's a very hard question. I think everyone you speak to will give you a different answer to that. But one of the reasons why I really wanted to give this talk is I want people to take away that basically no matter what you're doing, you are contributing to mental health around the world, and you can do it better. You can do more of it, and you can make a difference in your own way. I'm not sure that we necessarily need to have the priority, either we put all of our attention on maternal mental health, or either we put all of our attention on adolescent health. I think if we challenge ourselves to do what we're good at with an eye towards improving mental health and being really conscious of people in some of the most vulnerable situations who could benefit from our work and maybe we're leaving behind, or who we could better serve through mental health interventions integrated into our work, then I don't think we quite need to make that choice. That said, this is probably not my response, because I personally am really passionate about psychosocial disabilities and disability rights-based approaches. So I tend to focus more on what we call sort of severe mental health conditions like psychosis. But what a lot of the big funders are focusing on right now are the so-called common mental health conditions like depression and anxiety, and post-traumatic stress. And they're focusing quite a lot on childhood and adolescence to address this knowledge gap I raised earlier around prevention and promotion, with the idea that if we focus more research and attention on helping children and young people develop kind of a solid base for the future, there will be less need for the more reactionary treatment and care and rehabilitation side of the spectrum of intervention. So yes, now I've forgotten the second part of your question. What's the success of digital tools? Great. So there's quite a mixed evidence base for digital tools in low and middle income countries for mental health care. There's a lot of excitement about it because obviously when you have this fundamental challenge of a scarcity of human resources, the opportunity to sort of leapfrog these challenges in training and building up that human resource base by using digital solutions is just very enticing. But I think something so when I'm working on M&E, we oftentimes encounter folks who are really excited about digital data collection and monitoring and evaluation and all of that. But the first thing we want to do is go back and get our paper-based tools right and figure out how to get that system working before we move it onto a digital platform, because digital also comes with its own unique challenges and constraints. So for me, I think that we do need to do a bit of thinking about what really works in the context that we're working in before we then get too excited about converting those things to digital platforms. But gosh, I sound like a real naysayer about digital mental health, which I don't mean to, because particularly at a time like this, where face-to-face contact is extremely difficult or in some cases impossible, it is a really potent and important solution. But I guess my fear is that in our excitement over digital innovations in mental health and our excitement over cognitive-based therapy apps and things, we might forget the importance of getting the human element right first. That said, I can see Jasmine's on this call, and I wish she was presenting with me, because they're actually doing some really cool things in India right now to try and facilitate peer support and prevent the spread of very scary misinformation using very simple digital solutions like WhatsApp and text messaging. I think that might be the stuff of another seminar, Claire.
Yeah. We had another question from Alex Cohen. Could you please unmute your microscope? I don't know why. Microphone.
Great.
Hi, Alex.
So this kind of follows on from the last question, and it will sound familiar to you. Given the great range of MNS conditions and the great variety of settings in which development people work, where do you start?
Yeah, that seems to be the question on everybody's lips. For me, I personally think that the most important thing that you could be doing in development right now, no matter what area you're working in, is making sure that people with mental health conditions, with M&S conditions and psychosocial disabilities are actually accessing and benefiting from your work, because there are a multitude of reasons why they might be prevented from benefiting from them. And regardless of whether you're talking about common mental disorders like depression and anxiety, or severe mental health conditions like psychosis, everybody needs access to clean food and water in order to feel well and healthy. Everyone needs access to healthcare in order to feel well and healthy. It doesn't matter what your diagnosis is or what age you are, or any of these other kind of different factors that we've raised in this discussion about kind of where do you put your focus. I think it's really difficult, as Rochelle Burgess pointed out, to be talking about maintaining a good level of mental health and well-being when you can't provide food for your family and you can't manage your basic household needs. I'm not sure if that's an evasive answer to your question, Alex.
Not evasive at all, Grace. Thank you.
I think Alex and I both share a real passion for psychosocial disability research and disability rights. So it's tempting to just say, everybody do psychosis. But I don't think that's actually the right answer for everyone.
Okay, great. We had another question from Ann Stevenson. So I guess Anne said, I'd like to ask Grace a question about the COVIDization of mental health services and research.
Yeah, hi Grace. I feel like one of the benefits of the COVID-19 pandemic is that there is more of a focus on mental health than there has been before, but have you seen in your work so far the shifting of everything to try to put it to this COVID lens? Like, I feel like I saw an exchange on Twitter of someone trying to say, we do all this great work, and now how can we go to funders with it, push it now through this COVID lens? And have you seen that? And what are thoughts and sort of challenges of how to navigate that, but also like what's good and what's bad about that?
Oh yeah, that is such a challenge. We had quite I had a sort of mini meltdown on a call about this with our team after reading the tweets from the Gates Foundation indicating that basically they're only funding COVID work from now on, because essentially we are going to have to COVIDize our work and explain its relevance in order to access resources in the future. And that's really challenging, because what we've seen, for example, previously from the Ebola crisis or from the Ebola outbreak and now from COVID, is that weak and underprepared health systems are the problem, or they accelerate and worsen the effects of an infectious disease outbreak. And beyond that, inequalities in terms of poverty, gender, race, these things are all compounded in this extremely high stakes situation. And the effects of these outbreaks would be lessened if we'd actually done a better job kind of funding development work beforehand. And so for me, it's extremely dangerous that now we all have to kind of that we all now have to make a case around COVID in order to make a case for funding international development, because ultimately if we'd done a better job of that earlier, we probably wouldn't be in as difficult of a situation now, if that makes sense. So I do personally find it very frustrating, but I also understand it. And for those of us working in mental health, it can be a bit of an advantage, I guess, because as I said at the beginning of the talk, there's a real attention to mental health right now, because COVID has forced many key decision makers and people with their hands on the reins of international development into their homes, into difficult situations where they're not able to access the kinds of supports that they might normally have to stay mentally healthy and well, and to help protect the mental health and well-being of their friends and family members. So it's brought it suddenly really close to home. we used to joke that if you saw a country pass a bit of mental health legislation, the first thing you wanted to do was look at the prime minister or the health minister and see if they had somebody with a mental health condition in their families, because that was sort of the only way that they would stick their hand up and become an advocate for mental health. And I think the situation is making us all advocates for mental health, and that's really exciting. But terrible. And I find it frustrating that we do need to kind of COVIDize our research, because if anything, the situation is showing us that we probably should have been doing a better job before, and not just that we now need to do a better job in response. So it's a bit of a rambling answer, but I share what I suspect is also your frustration with the situation.
Thanks, Grace.
We had another question from Ruman Khan.
Hi, yes, hi Grace. So I wanted to ask about monitoring. Are there any tools that have been developed to monitor the mental health in the development context? And this is for non-professionals, mental health professionals. So I know mental health professionals have their own monitoring tools developed, but for people who want to incorporate something like an mental health intervention into education, for instance, is there any guidelines that you can help with that people could use to measure before and after the intervention and how it's improving?
Yeah, absolutely. So we dedicated, I think, an entire chapter of the topic guide to research, monitoring, and evaluation to help people grapple with these questions of, okay, you've now said I should be evaluating mental health outcomes, what next? And what's really cool is that there's a number of different screening tools for mental health conditions that have been developed, validated, and tested in low and middle income countries. That can be actually applied by non-specialists. So you don't necessarily need a psychiatrist to kind of go in and give everybody a diagnosis and rate their symptoms and then come back and do it later. There are screening tools that can help you to quantify symptoms and assess their change over time. But one of the really crucial things that we have to remember with mental health conditions, as well as other chronic health conditions, is that mental health tends to have a relapsing and remitting course, and you tend to pick people up or identify them most often when they're really not doing very well. And so through this thing called regression to the mean, if you're a statistician, or whatever term you use, basically once you follow people up, they're more likely to be doing better than they were when you found them. So it's particularly important to try and think about comparison study designs when you're looking at mental health, if possible. It's not always possible, but it's just something that I'd like to highlight since we were speaking about monitoring and evaluation. But there is a systematic review we did of screening tools for common mental health conditions a couple years ago, specifically for screening tools used in low and middle income countries, that's cited in the topic guide. And it makes some recommendations if there's not a screening tool that's been adapted and validated for use in the country where you're working, because we know that culture affects mental health in so many ways, and it's obviously going to affect how you measure it. If there's not one specific for the country where you're working in, there's some that have generally performed pretty well across a variety of different environments. And so there's some recommendations of which ones you might consider. But ideally, you should always be looking for a locally validated or even locally developed tool to do this because of these important cultural considerations.
Okay, great. We've got two final questions. One is from Isabella Chirico. And Isabella was keen to know if there's any publication that refers to adolescents to reduce stress during this period regarding COVID. Anything regarding adolescent mental health?
I believe there's quite a bit, actually. So our colleagues working on the Youth Friendship Bench in Zimbabwe, for example, have been working to develop a lot of resources for this. I think the best place to look is, again, our COVID page on the Mental Health Innovation Network, which has been put together with the WHO to kind of collate key resources for this particular time. But also what I forgot to put a slide about was mhpss.net. So they are sort of the other big knowledge management network in global mental health, and they're specifically focused on humanitarian situations and situations of extreme adversity. And they've been doing a really great job pulling resources together very quickly. So that's another really good place to look. I'm sorry that I don't have a particular recommendation for you, mine. I'm actually, I really don't do children and adolescent mental health research very much, and I'd be scared to tell you the wrong thing. But there are resources that are out there.
Okay, I think we've got, hopefully, Grace, if you don't mind, we've got another couple quick questions. John Mark Milano was keen to know of what educators can do in times of this pandemic to assist students from different walks of life and social status in terms of their mental health.
Great. I think that's probably quite a similar question to the previous one. So if you don't mind, I'd refer you to these really excellent toolkits for people who know a lot more about children than I do. Can provide some evidence-based guidance. Unfortunately, it's not really my area.
And we've got one from Martin Leahy. Since psychological concepts and theories are culturally limited and not universally applicable to mental health, how do research and mental health agencies transfer these concepts to cultural concepts of their partner organizations without doing harm and without acting in a post-colonial manner?
Yeah, this is a huge question and a sort of central debate in global mental health that we grapple with quite a lot. It basically goes back to these sort of universalist versus relativist ideas about the human mind and how it works, and when it's not working very well, what do we call it and how do we experience it? And there's a very valid position that some folks have that maybe these things are not comparable across cultures. I think that the field of global mental health is not necessarily a universalist perspective that everybody's mental health is the same. I don't think we're that far down the spectrum. But I think we have sort of landed on this idea from doing quite a bit of cross-cultural research around the world that, mental health is real and it may look very different in different circumstances, and really empowering people from local communities to identify it, to express how it works and what might be the appropriate interventions for it. That's really crucial to sort of avoid this imperialist, assumption that we've got it right in high income countries and we can go tell the rest of the world how to deal with mental health. Because I think for anyone who has dealt with mental health conditions in high income countries before, I think you probably know we don't have it right. So what we've worked for more so, I think, in the field of global mental health is to foster an environment of learning where we sort of try not to privilege one particular approach to mental health over another and try and have a fairly open conversation. But again, this is probably the stuff of another seminar with anthropologists like Alex on board to answer the tough questions.
Okay, thanks very much. And I think we're down to 1 minute and we probably have time for one last question. Marie Stamp, is Marie Stamp online? Or Anna, did you want to ask a question too? Because you seem to be coming up. And do we have a question from Marie? She's a volunteer peer mentor in Ireland. And the final question maybe is Jasmine Kalha, her question is, what are the lessons for the mental health sector to develop evaluation measures that will encourage more intersectoral work? And I think that's a really good one to end on.
Great. I think we touched on this a bit earlier when discussing the need to avoid sort of diagnosis as being the necessary prerequisite in order to do any sort of evaluation. We don't necessarily need to kind of label people as having a particular condition in order to be able to measure improvements to mental health and well-being. And I think there's already been progress in that area, specifically as a practical reaction to the logistical constraints of working in these environments where we can't send a psychiatrist, out into the field to do a full assessment of every single person who participates in our program. So I think we're moving more towards transdiagnostic measures, and even beyond transdiagnostic mental health measures to measures of well-being, which is tricky to measure, and there's quite a lot of work going on right now to define well-being cross-culturally and to be able to, you know, measure improvements of it in a reliable way. But I think that is sort of the next frontier that we're going to get to, and it'll be really exciting when we do that, because, you know, who doesn't want to know, working in any area of development, whether their work is improving well-being? Ultimately, that's all of our end goals. So I think that's an exciting direction that the field is moving into, and mental health has a place, but it's not certainly the only player in that research moving forward. I think it's going to be quite a big intersectoral effort to make that happen.
Okay, great. I'm very conscious of time now, and unfortunately we've run out of time, but I'm sure everybody would thank me. And Grace, that was a really informative seminar. Thank you for that. And equally, thank you for challenging us to both better inform ourselves and to contribute to mental health. So, you know, thanks very much for that. There's been a lot of chat that's on the chat. We'll keep that for you so you can engage with this audience further. And we'd like to thank everyone for coming to the seminar. Our next seminar, research seminar, will be in June, and we'll send out invitations shortly. Thanks very much, Grace.
Great. Thank you so much, Claire. And thank you, everyone. Stay safe, stay well.